we go. Then let's do this. Okay. Then let's do this. And we'll do this. And we're ready to go. Okay. Did you guys have a great spring break, impromptu spring break, even though I know lots of you were just busy. Okay. Any visit on this real quick? Any questions, anything, any clarifications? Anything from you guys on any of these topics? Okay. Do we want to consider a different lecture time for the summer? Okay, we don't need to answer this now, but probably in the next week or so, I'll pop this up in the WhatsApp and we can decide then. Okay, so just putting this out there for consideration, just think on it, kind of think what might work pretty good for your summer. I mean, if you just want to stay with the continuity just because it's already into your head at Wednesdays potentially, except for this week. I mean, but I appreciate you guys making this adjustment so we can just jump right back into Unit 8. But yeah, so just putting this thought out there, this consideration, and like I said, I'll bring it up in about a week, in the WhatsApp to see where everybody's feeling on it. Okay. Otherwise, let's jump into it. I know, well, I'm sure for some of you, some of the readings are kind of a little ways ago, so let's do just a little brain refresher. Somebody want to start us off with something that you read? We had, let me get to it. We had a section from Varney's, a section from Holistic Midwifery, some in prenatal postnatal care. Somebody start us off with a topic that they remember from the readings. Even if it was something that you felt like you really understood, just throw it out there. Let's just start a discussion topic just to get our brains back into this.
So my discussion would be Varney's chapter 3 with all the testing. I remember when I was pregnant with my kids, I didn't do a lot of the elective testings, to I don't know. I didn't do the Down syndrome. I didn't want to penetrate the amniotic sac. I didn't want to do any of that. Those were my choices, but just knowing that those options are out there, and part of, I guess my concerns on the whole testing availability is, I'm nowhere near your caliber of expertise yet. Someday.
Yes, there you go.
Yet.
Yes.
But that's just part of my learning process and trying to figure out, number one, who do I work with locally? Where can I get these, if she doesn't want to go to IHS for prenatals, can she still get the tests if she wanted the tests? A lot of here at IHS on Cheyenne River, we have prenatal. There's a doctor that comes, but all the women and girls go out. Rapid, Pierre, Bismarck. So
a good reminder of the process, you feel like, and maybe just knowing because I would imagine for especially for some of those genetic testing options, and we'll get into it a little bit today, but then when we go back around, because we'll do all of physiological pregnancy and labor first, and then we'll go back around, and then we'll go back to, you know, anomalies and risks and considerations. So we'll get a deep dive into it, but it's definitely a good thing to, you know, start maybe reaching out of who to have those local resource conversations with, because I would imagine that for almost all IHS situations, that particular testing would be a referral out. And, you know, and having that in your knowledge, in your index Rolodex, to know that if that's something that maybe an older mom is concerned about, like, then you can have that conversation of like, okay, well, this is where we can go and this is who we can talk to, but then this is the procedure that they're going to bring up. So, you know, as a way to create that conversation so that process doesn't quite feel so shocking sometimes. So knowing that, yeah, most likely you would have to establish care, and then it's going to be a referral out anyway. And of course, depending on the tribe's structure, health insurance structure, and or agreement with IHS, you know, because obviously it looks really different here on FB because our clinic isn't IHS. So sometimes the referral out process is kind of get a shods. Anyway, it's a good topic to start with. Anybody else?
I don't count, but I had to look up signs and symptoms of peripartum cardiomyopathy this week in Barney's.
Oh, you had a reference, Barney's?
Yeah, because
Barney.
I could not remember the last peripartum cardiomyopathy symptom, and it's the one that she had, so I looked it up.
Dang.
Yeah. So just to say, even with 20 years of experience, you might be digging through that book again.
Yeah, it's definitely a good book to hang on to. It's not one of your like trying to get some money back from your college textbooks. Hang on to it. Pearl, you popped up. Did you have something that you wanted to throw out?
Yeah, I think when I looked at the placentology and the embryo or the placenta and embryology, it was really cool to see it in an animation. So I did some YouTubing and looked at that process happening and broken down. Khan Academy I did just to kind of read about it. I needed to see it happening. So
Awesome.
that was cool for me to kind of just see it happening and like rewatch and re-listen to that and think about like all these little cells that they start out as little cells and then mitosis, and then you have them go to distinct spots within you know, the uterus and form the umbilical cord and the placenta, and the, you know, the blood going to baby will never cross with the blood of mom because of the way it is designed. So I thought that was so cool that everything from the start is like purposefully like has a place. And I couldn't help but think of like beads and like florals and beadwork when looking at all these cells and all these, you know, looking at the uterus and the fallopian tubes and this process. So that's what was top for me.
Awesome. When you seek out resources like that, do you want to, if you still have that one saved, if you want to throw it in the WhatsApp,
Yeah,
YouTube videos like that, because I love that stuff. That was definitely my jam when I was first studying it. And I mean, it's still pretty reflective in how I lecture, because I just need pictures and then I start blabbling, but that's how my brain works too. Did Cheyenne jump back in? She said her laptop crashed and it said error, so she's restarting it. So And we have a few more minutes, a little bit time left for this 20 minutes. So we'll just use up this whole 20 minutes and give her that time to get back in
Not
with
yet.
us. How about you, Amaris? Anything come up with the readings? Anything like aha moments or things falling in line, connections and things clicking that you've been seeing with the midwife that you work with? Or Shoshana
Sorry.
too. So,
Yeah,
but
I was like, sorry, I'm not feeling very well. I'm totally here and on it. I think that for me, really going over the kind of like the same thing is the beginning, because um, you know, like right from the beginning with the sperm and the egg, because it just, we do all the work that we do after everything's done, and like reading into all these chapters really brings it back and kind of like slows it down, like it starts from somewhere. So I really appreciated going back, like where we're starting and going through everything and over and knowing where to find it and or looking for it and starting through that. It's hard to get done with one and then go to the next part of, like, it's good that in the way that we're going down the list, but it's also like I want to dig into each one more and more too. So yeah, I appreciated that.
nice. Yeah, if you feel like you need to how Pearl looked up on YouTube for some animation, or if it's helpful more in a lecture topic too. The readings, I mean, they're definitely encouraged because we're not gonna lecture on everything exactly how it is in the readings, because we're trying to structure it that it's different information in from both spots too. So just to say that, to just, if you do, and if you have capacity and space to take deeper dives, by all means, and then like I said, once we come back around into I don't know if you guys still have your course outline when we sent it to you before you chose to come in the course, but we do everything from the physiological standpoint, and then we come back around. So then I think it'll end up probably being after our second in person, then we'll come back around to first trimester again, but it'll be, like concerns and risks and stuff like that. So yeah, we'll definitely be taking deeper dives when we circle back around to these topics too. Anything for Oh, there she is.
It's loud in the background here.
That's okay. We all have
I'll try to be short and quick. They're just playing. We're visiting I brought my kids, my older kids to we're in Missouri. And they're visiting their grandma, my ex-mother-in-law. So but I have my little ones here. They don't know her. So normally they would be helping me with the little guys. Anyway, I just really thought it was cool. Like I've had like shorter, quick versions of development, human development, and now just flipping through the pages of the one book, Before We Were Born.
Mm-hmm.
I brought my books with me. It was amazing to see and to learn more than just like the little bit that we learned in nursing school, and some of the stuff that we've learned in our other books that we have. But this latest book, this Before We Were Born, that was just like the coolest book ever. I'm just like a nerd like that, and
Mhm.
I have Pearl shared with us how the YouTubes. I have not had a chance to look at the YouTubes, but that's something I'll be doing too. Is just checking out the YouTubes, and having all this will be very helpful for me explaining to our families like what stage of development we might be in, and
Mhm.
yeah.
Mhm. Yeah,
It's
if
really
you
neat
guys,
for visual learners.
Yeah.
if you guys come across stuff like that, always and maybe you are in your student one, but feel free, there's a discussion board on the class platform on Teachable. You can throw it in the unit too. You can upload resources in the unit. And you can throw it in WhatsApp too. Okay, so yeah, for
And
sure.
it might be cool for your mom to be able to add those to the archive too.
Yeah. So yeah, if you can, and then we can add it to our resource list for the next cohorts, because you guys are pioneering the way of all the awesome things. Was Cheyenne able to jump back on yet?
Is she in the waiting room?
I don't see anything popping up. Oh, yep. Sorry. Thanks for telling me to check. Okay. Cheyenne, are you back with us now?
Yay!
Okay. Anything you want to bring up from the readings? We're just kind of waking up our brains, getting back into that thought process. Anything interesting? Anything that you really enjoyed in the readings?
I don't know about enjoyed, but I found I had to read that Varney's like 5 times.
Oh,
The
yeah.
chapters, the set of like 5 times I had to go, but it kind of gave me a headache. But reading it 5 times is kind of like okay. I started remembering more, and I started thinking about how much I'm forgetting of stuff that I've read in the beginning. If I had to read that 5 times to remember stuff, I was like, oh no. But yeah.
I was the same way first time reading through it. So I get you for sure.
So I don't know. I discovered this app. I don't know if anybody else has heard of it. Speechify.
Yeah.
You take a picture of the book,
reading the text,
and then it
right?
reads it to you.
Mm-hmm.
Yeah.
I'm kind of like a visual and a learner.
Yep.
Mm.
If
So
that would
having
have
it
been a thing,
read to me helped.
if that would have been a thing during my undergraduate, I probably would have tacked on way more degrees than I did.
And you can sign up for the free version.
Mm.
You don't have to pay for it.
Nice. Hey, anything else for the about the readings? And if something clicks when we're lecturing too, just pop in. Okay. Otherwise, let's get into it. Okay. So conception and implantation. What I wanted to say though too is so talking about the first early part of the first trimester, because so many women, they just don't know, right? You haven't missed your period yet, you're not tracking yet. So this early part can be a really good discussion topic when you're talking about, if you're talking about conception and trying to conceive, when you're thinking about being accessed as a resource, or those conversations, that can be a really good topic to include the first half of the first trimester and all the development that's going on, and kind of planting those seeds to pay attention to early conception signs. Anyway, that was just a sticky note that popped up in my head. I'm gonna suck down the rest of this coffee, and we're gonna have a fun night.
I love this picture. This is beautiful.
Right? Isn't it cool?
Yeah, she
Okay.
always finds the most flowery, whatever. If it can make a uterus out of plants, she'll find it.
Oh, I'll find it. I for sure will. Okay, so just revisiting the first week and a half, not quite 2 weeks. Okay. Ovulation, conception, or implant, no, hello. Fertilization. There we go.
I was like, dang,
Okay.
girl.
Nope. So ovulation, fertilization, and cell division as the follicular cell after fertilization is traveling down the fallopian tube. It's not a full blastocyte until it makes its way into the uterus, and then implantation. Okay, right? So this, for most women, this is all going on before tentative miss period has even happened, right? This is the first, what would be between the ovulation window and when they would be expecting their next period. Okay, so a couple different visuals, because I love pictures. And of course you guys will have these when I post this lecture. So yeah, same idea, different way to look at it. Kind of breaks the days down a little bit, but again, like this would all be going on in the first 10 days from their ovulation window. Okay, deeper look into implantation, what's going on. I want to, at some point, I would really like to find a picture, and if I was more artsy inclined, I would really like to see the difference, you know, because we know this is what the blastocyte is implanting into is the lining that builds up, right? And maybe at some time I'm going to come across a picture that's going to show the differentiation between the uterine wall and the lining that has built up, because it's the thickness of that lining and like the waviness.
Oh, like in the myometrium?
Yeah, the myometrium, thank you. It's the thickness that slows that blastocyte down, right? And that's where it implants.
Good fluff.
Yeah. And the thickness, the body's ability to create a thick myometrium, what gets shed if conception doesn't happen, is a reflection of health from their cycle. And that also reminds me, I'm gonna find a picture of it, but I just got turned on to this book. Shoot, what's it called now? Holy smacks, coffee needs to kick in. The fifth vital sign. And I haven't checked it out yet, but I'm gonna get it and I'm probably gonna nerd over it. But it's talking about just how, well, what I was told it's talking about, I haven't checked it out yet, but it's talking about how just the reflection of how your cycle goes is reflective of all these different aspects of health. So we're gonna check it out, and it's probably gonna end up being a recommended book later on down the road. But yeah, Twinsy's probably gonna read it before I get to. Okay, so again, we're still talking about, you know, but this is implantation, right? Nice and high in the uterus, how we really like to see it, gives us midwife wet dreams when it's a implantation in the top of the uterus, because again, that's telling us that there's a thick myometrium that was able to slow down that conception ball really high in the uterus. Right. Okay, and then just quick revisit of the hormone shifts that are happening. We're focusing on the first 12 weeks. So knowing where the levels are supposed to be, and if they were cycle tracking, you know, this can be really helpful information of if later on down the road, again, when we come back around to concerns and abnormalities, we'll take a deeper dive into when might you test, when your HCG levels, when might you recommend progesterone supplementation, and what's going on, like what that looks like. So we're talking about normal, what we should be seeing, because we're mastering physiological normal. So then when there is a need for support, it stands out pretty blaringly. Okay, so just a quick little infographic about the normal hormone shifts that need to be happening. Same idea with this one. Okay, so if she was regular cycles on top, conception has happened. So then that, and the big thing is that huge progesterone shift. And sorry, I'm thinking about my May gal that is still using transdermal progesterone, but we won't get into that quite yet.
We should do a case study on her.
Oh, we should do a case study. You guys, we are getting so many good case studies in the last couple months. You are so lucky.
So bad.
Okay.
I'm just a noob, okay? Take it easy on me.
Oh, but
Brutal.
we didn't get
brutal.
this. We didn't get all of ours. I don't know about, well, Twinsy might have, because her experience load was like 20 times higher than mine, 100 births a week. But I didn't get a lot of these as they're happening. I got a few with my preceptor, and I was actually telling my assistant, I was like, man, I haven't dreaded a due date like this since I was a student. Anyway, we're gonna have some great case studies next semester. Okay, so physiological normal changes, early pregnancy changes. Again, this is most likely you'll be creating these conversations when you're talking about family planning or trying to conceive or fertility counseling. Most of the time, women they might not even know that they're pregnant yet, or they haven't contacted us about support yet. Like, we miss this window a lot. Okay, kind of same idea here. They might, a lot of these, they might not register. Again, depending on where they are in their, if they're choosing to fertility track, or if they're wanting to try and conceive. So these can be questions, reflective questions, when they do contact you. Okay, well, this can kind of be like sussing out. Well, I wasn't tracking. I don't know when I conceived. My last period was mostly normal, I think. Okay, well, did you notice any breast tenderness, or did you notice any bloating or constipation, or, all of a sudden, did you go to the bathroom all the time? So most of the time, these are reflective questions if they don't know when conception might have happened. And I don't personally try and suss that out all the time. And we'll talk about, I'm kind of jumping the gun, but it's a little bit pertinent. If I have a woman that does not want to, or has missed the 8 to 10 week dates ultrasound, and she doesn't know what her cycle is, I'll create some of this conversation. But most of the time, waiting until I can measure the uterus is good enough for me to determine dates. But again, like I said, a lot of times we miss this portion of the first trimester.
And I've been getting a lot more people in the first trimester, like as soon as the stick is dry, because people know that I am filling up, and I don't have the leeway anymore of waiting until I can measure you at 28 weeks and going, oh, okay, you're 28 weeks. Let's do some math. But that is the way that I used to do it. but now I'm getting people that, like the stick is barely dry. They're 3 weeks, 4 weeks pregnant.
Yeah, and if you don't choose to have a large support area, that might not be a thing that you need to consider. But if you do have a
Right.
large support area, or if you do want to travel to different areas for whatever reason, you know, that might be something for you to consider in your support availability. So found some good pictures of early ultrasounds.
Endometrium,
changes.
myometrium, that's what I was thinking.
Yeah. Yep. So endometrium is, yeah, the lining that develops between your cycles. And again, jumping the gun a little bit, but not just your month-to-month health, but subsequent pregnancy, stacked pregnancies can influence how thick it can build up. But I'm going to stop that thought tangent because we will get to that. But we're just talking about normal. What's the normal change looking like? And again, most of the time we're not going to see these. We might miss this. They might not even know, you know, this is 6 weeks and less. Especially first time moms, they tend to miss this a lot more because they're just not tuned into those subtle changes. Okay, so more pictures, just because I'm a nerd and I found them. I was doing this at a birth and she had a 7.5 hour dystocia, so I had to kill some time. So I went sleuthing about for ultrasound pictures because it popped into my head. Anyway, I thought they were cool. And not a lot of us are ever going to get to see this phase, or, you know, not many of us are going to have readily available ultrasound techs in our pocket. Somebody might eventually. But yeah, any questions or reflections, just jump right in, guys. We're just going to go through, and a lot of this is going to parallel embryonic development, especially in that book Before You Were Born, which is a really cool book, Before We Were Born.
Before, I got a question.
Yeah.
Before, like when you were talking about dating a pregnancy by feeling the uterus, can like fibroids or cysts or things like that, can that affect your dating?
It could. Yeah.
Early for sure.
Yep, early for sure it could. So we don't, I mean, you can internally palpate as early as 6 weeks uterine change. I don't practice pelvimetry and I don't practice internal pelvic well woman's. I mean, I know how to do them, and we will talk about the theory. And if you guys decide to incorporate that into your care, and if you don't have the resource of an HCG stick or anything like that, and if you do decide to do an internal pelvic exam to, I wouldn't necessarily say confirm pregnancy, but infer pregnancy, usually between 6 and 8 weeks, there's enough of a uterine change that between the internal sensation and then kind of compressing the top of the uterus downward, it can infer pregnancy unless they have a history of cysts and fibroids, because that could create the same palpable changes of the yeah, it feels the same, but it might not be a pregnancy. Does that make sense, kind of, your question? Cheyenne, is that kind of where you're going with it?
Yeah, I was typing as I was just like thumbs up, but I was trying to write it all down.
Okay,
as you're talking.
Can't. Yeah, just shout it out, because when I share, okay. I can't see the emojis.
Okay.
Yeah. Open mic. guys, open mic. But yeah, it can, and especially if they still choose to not get an ultrasound between 10 and 20 weeks. And again, we'll talk more about case studies, but I had a twin pregnancy mom, and one of them was a blotted ovum, and she was measuring right on track until about 20 weeks. So, but we knew that one of the conceptions was a blotted ovum. Not the same as a fibroid, but kind of. It's taking up uterine space, and it was presenting with a uterine size that wasn't completely reflective of what was going on internally. Okay. Yeah, so just the big mile markers in each of these weeks. Again, mostly I included these so you guys have them as reference, because I'll post all these and then you guys can utilize them if you want to create presentations or however you guys want to utilize them as resources. Okay. But again, pretty parallel in what we're reading in the text too. I really like this picture, life-size reference, because so much of the times like, oh yeah, it measures this and measures that, but which is true, but my brain needs like real life size comparison. So I just thought it was a cool picture. Okay, real quick, revisiting cycle tracking, the hormone shift, if they are cycle tracking, but also if they're not, you know, and they're like, yeah, I don't really know, my days are kind of, or my cycle, I don't really know when my cycle's happening. You know, so having this solidified in your mind for when you're creating those conversations or trying to sleuth out when conception might have happened. Yeah. Okay, and then having a ovulation wheel, fertility wheel, gestational wheel. There we go. Gestational wheel. If they can at least tell you a day, the first day of their last period, you know, this can be a really helpful visualization of gestation.
Making a due date.
Wow.
Yep, making a due date.
Okay, more coffee.
Worthless.
Second cup of coffee, guys. I'm having my first letdown. My armpits are tingling. Sorry. I didn't think it was going to happen that soon after the baby left, but I guess so.
Is Dr. Jen in the waiting room?
Oh, maybe. Thank you for telling me. I don't see that pop up when I'm screen sharing. Okay, so gestational wheel. If you're practicing as a doula, sometimes you can snag these from the OB office. Not that I've ever done that or not done that. I plead the fifth. But you can get them. I mean, I'm sure we could get a stack of them pretty easily, huh, Auntie? This is probably something that we might have for you at one of the hands-on trainings. Maybe not. We'll see. But they're fun. But if you don't have one, and knowing this in general, majority, well, actually almost all, I would say 99.7% of the time, it's the EDD is calculated using Nagel's rule, which is arguably the worst one
Inaccurate.
to use. Yeah, it's the most highly inaccurate one. For a couple reasons. First off, I mean, it was created in what, 1570?
Yeah.
Something like that. 1740. I don't know, something like that. Women's bodies have changed a little bit. It's pigeonholing every woman into a 28-day cycle and a 14-day ovulation, which we know is not true. But this is the one, as far as I know, like this is ACOG standard, so all medical charts, everything is always going to be using Nagel's rule. And if they are a 28-day cycler or less, it is pretty regular. It's pretty good. Okay. But if they're not, oh look, I even talked about all the crappy things about it. I was really trying to waste a lot of time at that last labor. Yeah, and it doesn't take account for implantation bleeding, any variations in early spotting for any reason. It's not the greatest option, but it is what's almost always used, especially in this country. This one, Parkin, is better. It's not perfect. I mean, none of them is perfect because we're not machines. There's always going to be biological variation because everybody's body is different. It's better. My biggest issue with both of these is that, and there's no way to incorporate this variation in a mathematical calculation, okay? You're not taking into account stacked pregnancies, and you're not taking into account maternal age.
Or breastfeeding, or
breastfeeding, exactly. Any additional hormonal changes. So
Terex depends on that woman charting her cycle, like
religious.
religiously.
Mm-hmm. So if she's breastfeeding, or if she had been breastfeeding in the last 6 months, because that's going to potentially drastically change ovulation day. If she's a grand multip, so 5 or more, if she's within 12 months of having birthed, even if she's not breastfeeding, and if she's having any symptoms or any cycle changes that could be clustered into perimenopause, regardless of her age. Okay, so any PCOS, any amenorrhea symptoms, any eating disorder, any, if she's got metabolized stress, all of those can change your ovulation day, and none of these incorporate those conversations, okay? Because these are just mathematical calculations. They're not holistic conversations about the individual. Okay, any questions about, we're just calculating or determining potential EDD? Anybody need a coffee refill or a potty break real quick?
I need to pick up my food order here pretty soon, but I was going to say I've been playing around with Woods Nichols' rule, but I don't entirely love her either. So
yeah. Any ovulation wheel that you get is going to be going off of Nagel's rule, and any app, if they're using any app, all of those are going to be Nagel's rule. And I used to kind of try and figure out adjustments with that, but mostly now, after almost 15 years, I just try and contextualize the conversation of like, well, it's a guess. Okay, it's a guess, and your uterus doesn't have its calendar. So I try and contextualize the conversational for the mental emotional component of getting hyper fixated on this one date on the calendar. I try and always encourage or frame my conversation around the week. Okay, the first week of the month, or the second week of the month, or like the second half of the month. So I won't necessarily refer to the singular date. In my portion of the conversation, I'll always try and refer to like a whole week number, or the half of the month, or the middle of the month.
Yeah, I just say your term window.
Yeah.
This is when I'm going to consider you in your term window. Sometime between this day and this day, I think you're going to have a baby.
Yep.
Really, your due date for me is only so that I can have who I'm going to have in those term windows on my calendar.
Okay, any questions or thoughts so far?
Do you think that the push for women focusing on EDD stimulates some of the, oh my God, I've got to be induced on this date and go with whatever whoever said?
For sure. I mean, it's to stick into the assembly line style, you know. Yeah.
Thanks for clarifying that.
Yep, for sure. You know, and it definitely gets used against us more often than not.
Yeah.
Oh, well, you know, your placenta is 40 weeks old and now it's going to start to deteriorate, and it's all based off of a mathematical calculation that takes no account into biological variability or even women's bodies in this millennia.
So old school, old shit.
Well, if I remember correctly, Nagel's rule was developed in like 1740.
Yeah.
And I mean, just the social and economical constructs and that influence how our bodies function in the last couple generations. There's not a lot of women that I see that have a habitual 28-day cycle or less. If I kept track, I could probably 3 come to mind in my almost 480 some births that had a less than 28-day cycle.
Mm-hmm.
You know, and then the Nagel rule worked out very well for them, but yeah, for the most part it doesn't really.
Mm-hmm.
It, you know, it's definitely one of those things that gets written into gospel on your chart, and every coercive conversation is based off of that arbitrary date.
Nagel's 1812
Okay, 1812.
in Germany.
Somebody was 1740. I don't remember. Anyway,
I think it's who Nagel
poached his
practiced, basically, because it was the guy that he did the textbook from.
Oh yeah. Okay, anything else? Okay, so pregnancy history, knowing what it's talking about and how it gets broken down. And again, pretty parallel to what we see in the textbooks too. But if you see the big long drawn out number, you know what, knowing what it's talking about.
Yeah, the GPs.
Yeah, most women, I mean, if they know, it gets shortened down to your G's and your P's. Most OBs don't go to the expanded version that I know of recently. So anybody want to share their G's and P's? Or I'll tell you my history and you guys can figure out my G's and P's.
Oh yeah, I can tell you mine too.
Okay, so I have had 6, no, shit, no, I don't even remember. 5, 6, 7. I've had 7 term deliveries. I have had 6 confirmed. I've had 6 confirmed spontaneous pregnancy losses. And I have 6 living children. Can anybody find the potential? What, because anybody want to throw out what your potential thought is? Because there's a number in there that doesn't necessarily match up.
Did I tell them?
Any thoughts? I can't see if there's anything in the chat.
So would
Please.
it be 6, 3, 0, 6? Is that right?
7. I've had 7 deliveries.
7. Oh. Okay. Because you still count twins as one.
As
Twin
one.
counts as a G1,
Mm-hmm.
but your para will be different.
Yep.
Okay.
So like in the example, she's a para 1002. It's because she's had 1 term delivery, but she has 2 living children.
Yep. So mine would only show up if you did the drawn out. Okay, because otherwise my full term loss, if you just did my short G and P, you wouldn't necessarily catch it.
Right.
But if you do the long version,
So she would be a G13 or G12P7. I have to look through your chart and see what I have you listed as.
well, it would be a G12P 0
P70.
6. It'd be a P0016.
Yep.
Yeah, which would, yeah, something like that.
So I am a G8 P4 technically, but on the new TAPL, I am a G8 P. I've had all 5 of my babies have been term deliveries, but I only have 4 living children.
Well, you'd be a P0.
I'd be a P4,
Oh no, mine would be like P.
no preterms, technically no abortions.
No, but
only
full term, then this is why I don't like the long drawn out one, because
Right.
there's no differentiation unless you do the TPAL. There's no differentiation in the G's and the P's for spontaneous, like 8. There's no differentiation between a spontaneous 8-week and a full term intrauterine demise or a loss in active labor.
right.
Oh, I could read that.
So you either have to tell the physician that you've had a stillbirth, and a stillbirth now is anything over 20 weeks.
Yeah.
It used to be age of viability, which used to be like 26. Now it's like 22. So now they consider you a stillbirth anywhere from 20 to 43 weeks.
Yeah.
Which
is
also messes up your TPAL.
Yep.
So when I do it, I do term deliveries, preterm deliveries, spontaneous abortions. So I make a distinction between how many spontaneous losses they've had and how many terminations they've had. because it's a different, what you're looking for, actually how it affects the uterus is different. And then I look at living, how many of those term deliveries produced living children? How many children are still alive?
Yep. And that's how I break it down too. Like when I'm talking about pregnancy history, because I ask for gestational age. So if they had an early term loss or a later term spontaneous intrauterine termination, or if they had an accident and the pregnancy naturally aborted because of the accident, I feel like it's important to distinguish the differences.
And sometimes if you have a woman with a history of some spontaneous losses after a termination, you can talk about some different uterine encouragers and things like that. Because the action of that is depending on how that method was done, can affect future fertility. So that kind of comes up in your preconception counseling.
And the emotional aspect too. You know, there can be a lot of latent emotional things. And I ask about this in a consult, and then I ask about it again at my first prenatal. And then if they volunteer more information around whatever events, okay, I just listen. But then I put a little sticky note in my brain hole and be like, okay, this might be a thing that we have to revisit again. And sometimes the opportunity comes up in subsequent prenatal care, sometimes not. And sometimes you have to watch a woman deal with 7.5 hours of emotional dystocia, and all you can do is watch. But by knowing that could be, the only reason why I knew that was probably what she was going through is because I knew the history. And this can definitely be in VBAC situations for sure. And everybody's different, you know, if they want to just emotionally puke all over the place, or if you can't even crack it open with a crowbar. But one way or the other, it's going to work itself out. And sometimes it's
I'm sorry.
2 boxes of tissues and the antenatal support, and sometimes it's a 7.5 hour emotional dystocia that you just sit at the table and watch what's going on, because her husband's like, well, we could talk to Jane about this, and then she says, I don't want to talk to Jane. I'm like, okay.
I'm sorry.
It's okay. It's okay. But the whole point of it, knowing this is very helpful. It's not just about, you know, what's happened in her uterus. Okay. Are these things that you need to know about to put little markers of like, okay, well, is this something that I might see play out mental and emotionally later on down the road?
I'm sorry.
Okay. Any questions or thoughts about this?
So I shared mine. I don't know if you can see the chat. So mine would be at G3P30023. G3P30023. If you're differentiating between spontaneous and voluntary.
Okay. G3.
I saw that.
Okay.
Good job.
Nice. Yep. Okay. Okay, so placenta in the first trimester and reasons for spotting. Okay, so another visualization of what's going on in implantation. Okay, because where the implantation starts, this is the placenta developing. Okay, and then that layer, once the zygote kind of burrows in, the layer that forms from the myometrium that goes over the blastocyte, that's going to be the outer layer of the membranes, because you got the amnion and the chorion. Okay, so the cell ball creates the inner layer of the membranes, and then the myometrium creates the outer layer. Right, so just a cool picture, I thought.
Shoshana, I think, is in the waiting room.
Oh shoot, thanks for telling me. Where's she at? I don't see her. Somebody want to tell her to try again? Okay, another explanation of what is going on, and this is all going to make a lot more sense, like all this development stuff going over again, once we start looking at placentas and we see the margins and we see how they develop. And if you get a hold of a placenta, take a look at the maternal side, because you will see, it will show you how deep that zygote was able to burrow in, which is reflective of how thick the myometrium is, which is, you know, going to tell you that the placenta is going to tell you everything you need to know about health in the first, well, about 3 cycles prior to, and the first 14 weeks of pregnancy. Is she back in the?
So
Oh no, I don't see
14 weeks puts us into the beginning of the second trimester then, huh?
Yeah, so the first, it's the placenta structure is all the first 12 weeks, and then that's gonna lay the foundation for how it's able to function. And then, you know, and a lot of, if there's going to be considerations like IUGR, SGA, which you're not going to see until the 3rd trimester, but all that framework was laid down right now. But this is also could be a good segue into talking if you're being asked to support with conception and fertility. This is very reflective of the partner's health. Like, there's a lot of research coming out about the sperm health is a direct indicator of the uterus's ability to build the placenta. Oh, there she is.
That's exciting.
There she is. Okay, so again, cool pictures. So we're and then this is after those structures are able to form, you know, now we're into probably 6-7 weeks gestation, because there's still a yolk sac, maybe 5. But yeah, this is why it's so important. Okay. Also, this is, I mean, all of these, think of all these fail safes, all these checks and balances, all these things that have to fall in line for the pregnancy to stay. You know, that's why statistically, pregnancies that even get into the 2nd trimester account for depends on the literature, 20 to 27% of conceptions that actually happen. Okay, because if this doesn't happen correctly, it's never going to get here. Okay, and then just another cool picture of why this is, I mean, so the formation of the amnion chorion, the formation of the placenta. The margins haven't developed yet because this is probably right at the end of the first trimester. And the placenta function doesn't become independent until 22-ish weeks. So
Can I ask what's underneath that, the picture? It says placenta and then there's another line. What's the word? Okay, uterine. Got it.
Yep. So it's not separate tissue yet. You can't see you won't see distinct placental margins by the end of the first trimester yet. So that's why if you support somebody with early loss, like if the pregnancy were to spontaneously terminate at this stage, very likely the only distinguishable structures would be portions of fetal structures, because the developing placental tissues would look like normal menstruational tissues because the myometrium, it's all one piece right now. Okay, making sense? Some of the reading starting to click into. Okay, so potential reasons for first trimester spotting. The number one, subchorionic hematoma. As the placenta tissues are starting to differentiate, a little portion of it pulled away. And the theory is if a pregnancy gets to this point, that when those tissues start to differentiate, this is the most likely common, what am I trying to say? This is the most common reason for like that 10 to 12 week where they know that they're pregnant. They probably missed their period. They probably gotten at least one positive P stick. And for whatever reason, when the tissues were starting to differentiate, the separation happened. I mean, there's not a lot of, correct me if I'm wrong, Twin, but there's not a lot of hard research out there about first trimester losses or bleeding. Subchorionic hemorrhage, subchorionic hematomas, it's really hit and miss to even see them on ultrasound.
Most of the time, by the time people go in to have them seen on an ultrasound, they can only see it either actively bleeding or actively resolved. They don't actually see the blood bubble. And that subchorio, it can continue to get larger.
Yeah.
Until it actually can then, jockey for space with the baby. But I've only seen a few subchorios go to term. Most of them end in an early trimester loss because you can see the placental edge coming off of the portion of the uterus there.
Mm-hmm.
And that's what ends up, but there is not a lot of, there's not a lot of education on there. There's not a lot of research on it, because ultimately this doesn't actually help doctors and facilities. So,
yeah.
And there's too many variables. It could be chromosomal, it could be blood typing, it could be incompatibility. Yeah. Like there's a million.
And there's not a lot that they would do or could do to support it or stop it or resolve it. And the majority of the time, it's not fixable. If it's gotten to the point where it's not implantation bleeding, okay, so it's not in that 8 to 10 day window. If it's like that 10 to 12 week window, and it more than likely, it's already gotten to the point, because for this pool to get big
Well,
enough to either finish
there's already been a
pushing-
fetal demise. Yeah.
yeah, the fetus is probably not viable anymore, especially if it is like in this picture, because for that pool of blood to get heavy enough to either push the placental tissues away from the wall or come around the edge of the gestational sac, it's the pregnancy is probably not viable. Okay, other reasons, there could be the establishments of a placenta previa. This, they would be able to see potentially a tentative early diagnosis on an ultrasound where it is a low implantation and it is either incorporating or covering a portion of the cervix or the os or both sides of the cervix. Yeah, a complete previa or a partial previa, probably not a vaginal birth, probably definitely not a home birth situation. And we'll get more into this later. Mostly the point is like this is a potentiality of, and most of the time, if this is the case, you're actually not going to have breakthrough bleeding until the early part of the second trimester. So usually not, because once the uterus starts to elongate is when this will show itself. Okay, chemical pregnancy, where the body thinks it's pregnant, but no conception has happened, no implantation, and the hormone shift is struggling to actually start a normal menstruation. Okay, blighted ovum is another reason why there can be bleeding in the first trimester. So conception happened, implantation happened, placental development started, but fetal development did not start. So it's an empty gestational sac. Okay, and then a molar pregnancy, where conception happened, implantation happened. Fetals may or may not have started, but the placental development kind of went wonky donk. And there was more or less kind of like uncontrolled, unchecked, rampant placental tissue, placental structure that tried to start developing and kind of went off the chart. And it ends up in either cyst sacs or fluid buildup or something like that. A lot of times, if either of these are the case and they're not having hospital-based care, sometimes what you'll hear is like, yeah, I had a period a couple months ago, or at one point that was like, I thought I was pregnant. My time was a little bit late, and then it was just a really super painful, lots of bleeding, tons of cramping, headaches. Like I was really sore. I felt like I had the flu on steroids, but it was really just my time. So I don't know, but then it never happened again. But it was just that one time that happened. That could definitely be a situation where either of these are happening.
Can I ask a question?
Yeah.
Is it typical for the medical profession to brush these off as we don't know and you're young and so try again?
Yeah, it could be. I mean, it depends
Depends on the provider.
The provider. They might some providers might be like, well, we'll just do a ultrasound. I mean, it depends on how recent this was, because these two situations, that pregnancy is not viable. Like at some point bleeding is going to happen. So They may or may not order an ultrasound. They might just do like a protocol DNC. It depends on the provider of their explanation or their brush off or, you know, their follow-up care. Because it's
And some want to do
they
all
would
the things.
still-
Some want to do quantitative HCG for 2
Yeah.
weeks. And then if you're not bleeding, have you come back in for a DNC. They want to be testing you for sepsis and all these other things. And for a
Yeah.
woman that's dealing with a loss, even though that's super, super thorough and it sounds great in theory,
It might feel
it's
helpful.
really hard. It's
Yeah.
really hard.
Because in both of these situations, you would get positive pregnancy tests.
Right.
Like you would,
Yeah.
if you got sticks from GNC or not GNC, CBS.
Right.
And you might still, even though neither one of these are going to go into the second trimester. Okay. So that's
Right.
potentially 10 weeks of getting
You thinking
positive
you're pregnant.
getting positive pregnancy tests, having pregnancy symptoms, and sometimes, especially in molar pregnancy, because the body knows something's off kilter. So you'll feel horrible. But you
Right.
think you're just early pregnant. And you might have some breakthrough spotting, but then all of a sudden you have like the worst menstruation you've ever had, because the longer
Mhm.
that a molar pregnancy goes on, the more
More mess it makes.
the more mess it makes. The majority of the time in a molar pregnancy, it doesn't self-regulate. So the uterus just keeps filling up and filling up and filling up and filling up. And by the time that it is either heavy enough or
Mhm.
that the cervix can't support that weight, like that can be a very, 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 very bloody period, seemingly late period.
Which is why a lot of providers will recommend a DNC on a molar, just to try to make sure that you get it all.
Yeah. Yep.
And that you bleed a little less with a DNC because some of it is done during the procedure.
Yeah. But without labs and without ultrasound, these are very hard for us to distinguish what is going on at home. And especially because like a lot of times we don't get called in for support in early pregnancy. Sometimes, you know, we'll get called in for miscarriage or suspected miscarriage support. And knowing what tissues we might be looking at, knowing a normal amount of early spontaneous pregnancy release bleeding, you know, and sometimes they want to know, sometimes having the information that, well, this was probably a molar pregnancy can feel helpful to some women. Sometimes it doesn't. Okay. So I guess kind of gauging it, like what information feels helpful to her, or what might not, you know, because some women want to know why. Okay, well, it's a molar pregnancy, and then they do their own research.
Did you?
Or some women feel like you're trying to tell them that you didn't actually have a baby, so then it doesn't feel helpful. Because technically there was no fetal development, potentially, or very little.
Right.
And then that piece of information doesn't feel helpful.
Did you look in the chat? Did you guys cover Shoshana's partial previa?
No, I don't. I can't see what's going on in the chat. Okay, so what's the question?
Okay. Well, I think maybe that she had a comment about some uterine spotting is what I'm assuming. And she just says, I had a placenta previa low lying. So that would also cause early first trimester spotting. It could be a low lying placenta, and you could have a viable pregnancy.
I did.
Yeah.
My first one. Yep. My oldest one, my first known pregnancy was with my oldest daughter. And I didn't get care till like about 5 months in, and found out that I had a low-lying placenta previa. And then they said, well, maybe it'll grow up as your uterus gets bigger. And it didn't, but I had spotting early.
Yeah.
And I was at a point in my life I didn't like watch my cycles or anything like that at all. I
Yeah.
just knew I
Right.
was super tired and super tired all the time. I didn't have morning sickness or anything, just tired.
Yeah.
Um,
So
and
sometimes, okay, go ahead.
nope, and that's just basically it. I had a low-lying transverse, so that I could have, and like my other children were natural childbirth, so
Yeah.
that's it.
So your
Okay.
previa never moved up?
Nope, did
Yeah.
not. And then when I did the I don't know, I never saw any notes or medical records, but I bled
Yeah.
horribly.
Mhm.
Postpartum, like a week after, I passed clots that would fit into the palm of my hand.
Yep.
They're like,
Yeah.
"You're okay."
Yeah.
I don't feel okay. Yeah. So it is possible for some spotting in the first trimester to be previous, usually marginal, usually more of the third or fourth degree previous that might not resolve will spot early in the first trimester. But for most women, the uterus doesn't become full enough to start growing, the fundal to start rising until after the 6-week gestation. So most previas will be early second trimester, like that 14 to 17 week spotting is most likely a low-lying placenta that is starting to move up as the uterus is starting to stretch up above the pubic bone. So it's not common in the 12-week and less time frame for any spotting in that time frame to be a previa. It is possible, but majority of the time, like I said, that 14 to 17 week, that's usually a low-lying placenta. Some either a first or second degree previa. Thirds can resolve, but fourths usually don't because there's usually some aspect of it going across the os into the other side of the cervix. Okay. Okay. RH factor.
My favorite.
Oh yes. There's a couple good RH books and we'll throw them into the WhatsApp. But the basics. Okay, so the basics. RH negative is a concern, right? An RH negative mom who conceives with an RH positive dad. Okay. The initial pregnancy doesn't usually cause a problem. If that pregnancy gets past the first trimester, okay, then probably not going to be a problem. But if she is not a first-time mom and she has had a RH positive baby, okay, and she has developed titers, so if she hasn't had a titer test, she doesn't know if she's developed titers, then the subsequent pregnancy with an RH positive baby could be the concern. Okay, and we'll visit this a couple times because it's tricky to get a handle on mentally, or it was for me. I don't know. I'm sure you guys are smarter than me. It took me a hot minute to like sort this out in my brainstem. And how ROGAM can play effect in this or not. Okay, so disclaimer, Native populations has the statistical lowest rate of RH negative blood. So the likeliness that we find this in our communities is thankfully pretty low. Statistically, most common blood type in Native country is O positive. So lucky us.
Yes, you'll see it a lot in women of Scandinavian descent.
Yeah.
Believe it or not.
Well, the
Everything.
most common, and a lot, it's still less than 10% of the female population. So
yeah.
Of any one racial influence. But it's like the last time I looked at it in Native American, it was like 1/7% or something It was, it
Yeah,
was-
isn't it like less than 0.004 or something like that? 0.0.
yeah, yeah.
Yeah, it's a really minuscule.
It's really, really
Number.
low. But this still could be helpful information if it is a Native woman who has a white mother. That could be a potentiality. I carry Eldon cards in my bag for this reason. And it's a blood test. Prick your finger. You can get them off of Amazon, ELDON, Eldon cards. Because my first question is, well, what's your husband's blood type? Well, I don't know. Well, if your husband isn't Rh positive, then you have nothing to worry about. Was your previous baby ever typed? Well, no. Because so much of the time in their clinical history, it just gets fixated that she herself is Rh negative, and the rest is seen as superfluous information, when in fact it is not. It is very, very important information. I'll do Eldon cards. I'll even do Eldon card on the baby from the umbilical cord. I won't stick the baby's finger or foot or anything like that. But if baby is Rh negative, then she doesn't need RhoGAM. She doesn't need RhoGAM. I mean, it's hard. There is a RhoGAM shortage, and it's hard for midwives to get RhoGAM anyway. And depending on your state, it might not be legal for you to get RhoGAM, but then you don't have to make a recommendation for them to go into the clinic at 48 hours postpartum to get the RhoGAM shot that they don't need because baby is Rh negative. Or she's a first.
Are we going to cover the Unity screen?
We will, but
okay.
I mean, yeah, now there's home tests where you can do the titer tests at home. So and it's the Unity screen.
And we could test your baby's blood type in utero.
Yeah.
Which is pretty
so
wild.
Now there's all kinds of at home. I mean, you can get the baby gender sneak a peek blood test at CVS. I mean, if you really want to, but yeah, there's a book. When we get more into the placenta function, we'll do a whole unit on that, and then we'll do a whole when we come back around and we do complications and considerations. What's her name? The anti-D book.
Sarah Wickham, Dr. Sarah Wickham.
But we'll have it on the list so you guys don't have to worry about it. But this is the first exposure. Okay. So
if you also have somebody like Betty in the case study, I'll give you guys a hint. I don't think anybody in their case studies picked up on it, but Betty is a Rh negative mom with a Rh positive dad. And that was why she had all those losses.
What blood type is me?
Yeah, so somebody with a lot of if they report a lot of spontaneous early term losses, that could be a source. And if they don't know their blood type, that could be part of the conversation for sure. Especially if she's never had a successful pregnancy or has never had clinical support. She wouldn't know, it wouldn't be on her records. Any questions about this? Okay, so again, a couple things have to happen now, and I have supported Rh negative moms. Some choose to get it, some choose not to get it. In the clinical support, they'll usually give you a shot of RhoGAM somewhere around the 28th week, and then immediately after baby. But that protocol is different depending on. I've heard up to 4. 4 is the most I've ever heard. 2 in pregnancy, 1 in active labor, and 1 before she was discharged. And I was like, hot damn, how is that bill? Anyway.
Yeah, what the idea is that the RhoGAM shot lasts for 12 weeks. So 28 weeks should get you to 40. But then if you're in active labor and you're at 41 and change, then you could potentially not have protection. This is how they argue it. You could potentially not have protection. And then if you have an Rh positive baby, well, then you need it. You shouldn't need that the 48 to 72 hour dose, but they will often make you get it anyway. Just, just in case. Even
And
though it's
majority of the
biologically
time-
impossible that your labor dose didn't work.
Yeah. And majority of the time, they still haven't typed baby, and
Right.
they still haven't, or they won't do the titer test.
Or they haven't typed baby and it won't come back.
Yeah,
It
or
won't come back until after the 72-hour window.
Yeah.
So they give you RhoGAM, but then you didn't eat it because they call you back at 1 week and tell you that your baby is Rh negative.
yeah. So, but the concern is, okay, well, so a couple things have to happen, right? For a mother's body to develop titers, because just because she has an Rh positive baby does not guarantee that her body will develop
She's got
titers.
antibodies, right, that
Okay.
she's got sensitized.
Yeah. Okay, so blood crossing has to happen. And just because the placenta comes into maturity and she has a full-term pregnancy does not mean that blood crossing has happened. Majority of the time, some sort of abdominal trauma or labor trauma has to happen for those two blood types to come into direct mixing, because even though there's a placenta, those two bloods don't directly come into contact, right? Like there's
Unless you have a subchorionic hemorrhage, that will be a
Yeah.
deciding factor. That's your only other first trimester factor in that.
Yep. So some sort of abdominal trauma, a subchoreo, a placenta, or previa that's drying up, okay, or later on in pregnancy, a direct abdominal trauma that results in bruising. Okay, so sometimes, and again, kind of jumping the gun, but we're going to revisit Rh factor a couple times because it takes a little bit for this to solidify, and or maybe that's just me. Anyway, so it has to result in abdominal bruising, that there was enough trauma for there to be exterior bruising. So not just like, oh, I slipped on the ice and I fell on my butt. Okay, but like a car wreck where the seatbelt left external bruising. Okay, in labor, forceps delivery, vacuum delivery, episiotomy, surgical birth, those are all non-natural sources of potential direct blood mixing. Okay, and the anti-D book, when we get to it, does a good job of laying out, it still doesn't guarantee that titers will develop, and RhoGAM does not guarantee that it will stop. Okay, it reduces the chance. Okay, and majority of the time that's not in the conversations. And for some women, again, like I said, Native Americans have the smallest statistical percentage of Rh negative blood. But for some women, they don't want to go through that process if there's no guarantee. Okay, it reduces the chance by like 60% for most women. But I believe in transparency and for women to decide what hill they want to die on. If they don't want to go through the hospital, or if you can't source it, you know, and some Rh negative moms are because there's other Rh negative women in their family, they're just like, yep, we have lots of miscarriages because I'm Rh negative, but I'm okay with that and I don't want to do that. But anyway, enough on that for now. Any thoughts or questions on that? Boy, we're clipping right along. I'm either really boring or you guys are like really smart. I'm gonna go with you guys are really smart. So again, most of the time we kind of miss this window. But conversations with first trimester supplements, nutrition, and herbs. I might get consultations at this stage. Not very common for me because I don't have a closed calendar, or I mean high demand, like Jade has high demand right now. But my biggest conversations are protein load. I mean, the protein is a sexy word to me. I fit it in wherever I can. Most of the time they're already on a prenatal, and where's my train of thought going with this twin? I'm out of coffee, guys. What the heck?
The train of thought is that they're on a prenatal and they're pretty committed to it, and they
Yeah.
don't always want to hear like, hey, this is pretty synthetic, or hey, it might be helpful
Oh.
for you with what I'm seeing. You're gonna have XYZ.
Well, and so many of the times, especially if they've been doing care through the IHS, they just get whatever IHS prescribes, right? And that's not a bad thing. It's not a bad thing. So then
you can beef up their food if they have access.
Yeah, sometimes focusing on conversations around protein, and even, taking into consideration that we're probably going to be supporting homes that are sustained on either commodities or resource limitation. And in a perfect world, whatever, I won't get into that thought, but even if we just focus on proteins, like, peanut butters and nuts and like whatever we can, and with the tribal families that I've supported, that's the avenue of that particular conversation that I have found to be the most receptive, because a lot of times that's just the truth of our communities, right? Whereas there is enough protein sources, even if they are only able to sustain on commodities, that what the heck? What's my point? I try to remove as much shame out of processed food diets as I possibly can, and I have found that focusing on protein sources is the easiest way to do that. There. I finally found my point. Okay.
That's beautiful.
And if you decide to incorporate a first trimester tea blend in your support as just something that you provide, the Nora tea blend, Nora, so nettles, oat straw, red raspberry leaf, and alfalfa, that's basically like it's a herbal superfood blend that whatever is lacking or not quite there in either the prenatal, that's
that'd be a nice stopgap.
Yeah, it's a really good gap filler.
And it tastes good.
What's that?
I said it doesn't taste bad.
Yeah, it doesn't taste terrible either. I think alfalfa tastes really sweet, but that's just me. My only cautionary thing in this trimester is vitamin C source, because everything is vitamin C fortified, right? Like vitamin C this, vitamin C there, especially processed foods, processed diet. Vitamin C can have an abortifacate action on some women because it makes the implantation site slippery. Okay, not all women.
Angry.
Yeah, not all women, because everybody's threshold of response to that is different, and you don't know where that threshold is until you reach it. Somebody's threshold might be at 4,000 IUs a day. Somebody's threshold might be 9,000 IUs a day. Okay. Now, food source vitamin C, you don't have to worry about it because the body is going to absorb what it needs and pass on what it doesn't. Okay. But synthetic vitamin C kind of hijacks that system and oversaturates. And when it oversaturates in the bloodstream, then it makes an angry uterus and a slippery placenta site. Okay. So that could be a good question if she's experiencing first trimester spotting. It's also a helpful piece of information if you get called up by somebody that is wanting to intentionally release a pregnancy. Not necessarily because that alone will do it, but that can be a helpful component to other things that are being done to encourage that pregnancy to release. And we'll talk more about that later on too. But
I have a question.
Yeah.
With the Nora tea, is it okay to have because I know we don't recommend the raspberry leaf until they're like 36-ish weeks. Just, I know it is a uterine toner, but I mean, is there other evidence that supports like this is okay in the early part of pregnancy or the second trimester? Just because I know that's kind of how we refer for the Nora T, is like when you're closer to full term.
So you can do it closer to full term for sure. I don't always love it in the first trimester, because it can cause some cramping. So I tell people, like, if you have a cup of this and you get a little crampy, stop taking it. But the uterus is a muscle. So waiting until the very end to let it practice on itself is not always, you know, the best thing. And it depends on, I prefer Nora tea over just straight red raspberry, because straight red raspberry, they're drinking a pitcher of it a day.
Yeah.
Nora tea, you can stomach about a cup. And so how much they're utilizing is a little bit different.
So for me, if I recommend,
I tell them to start it in the second trimester if they're worried about it.
Yep. So for me, when I recommend Nora tea, it's usually a supplementary thing. Like it's not a main source. Okay. So if they're not able, it's not a standard recommendation for me because of that. And I don't know how somebody's body is going to respond to that. But if they're struggling with nutritional food sources, if they're not able to access supplements regularly, it is something that I have in the past and I will absorb that and provide for them. And I recommend 1 cup every other day. Okay, because I don't want the body to hyperfixate that on the source. I have found that it can be helpful for appetite stimulation, some amounts of, early morning tummy yucks, not necessarily full on morning sickness-ish. But if they're kind of tipping over into that wonky, like sleeping ketoacidosis, where then they're not hungry right away in the morning. And I'll usually recommend that you make 1 cup, but then you pour half of that into a cup of water. So you're only still having 1 cup a day, but you're not having it all at once. Okay, and then they're sipping that on the side. So it's more like kind of like an electrolyte mix idea. Because I'll usually recommend, add a little bit of honey to it, add a little bit of salt. You don't have to taste the salt. But it's in support of encouraging the body to finish those hormone shifts, because that's something that nettles and oat straw can do if the body is kind of struggling in that progesterone shift. And if that's where some of those struggles are coming from, like the feeling of morning sickness or something, it can be because the HCG is trying to stabilize, but the progesterone hasn't quite caught up, and then I'll check in with them right away, any cramping, any stomach discomfort, and then I'll make it clear, like, we're just gonna give this a shot, see if this helps your body until about the 12th or 14th week, and then we stop, right? Because again, you don't know where somebody's vitamin C saturation level is at. And in my Nora blend that I make, I usually do a one part nettles, 1 part oat straw, a half a part red raspberry leaf, and 2 parts alfalfa.
Thank you.
You're welcome. Thanks for that question. Because you do see that, and it kind of depends on the herbalist that you talk to, kind of. Some of them are like, oh yeah, you can totally, but in my experience, those are also the ones that say that you can take motherwort all pregnancy, and then I just stopped listening to them because I think they're quacks. Oh, herbs. Okay, so and lots of midwives will recommend peppermint willy-nilly, and that's one that I kind of approach with caution. Okay, especially if she's tandem nursing, because some women it'll make them dry up. It will adversely affect their supply, especially if they're wanting to nurse through their pregnancy. So peppermint is one that I approach with a lot of caution. Again, because you don't know how somebody's going to react to it unless they tell you, yeah, I drink peppermint and I can roll in it and I can drink mainline a pound of it and it does nothing to me. Unless they know that piece of information about themselves, that's one that I recommend with caution for specifically for morning sickness. I utilize ginger first, partially because it's really easy to access. You can pretty much go to you can go to Walmart and get a piece of nice ginger root. Same with raspberry. Raspberry leaf, again, I by itself, that one I'm kind of reserved on my recommendation.
And I only use false unicorn if she has a threatened miscarriage.
Yeah, yep. Weird, literally what I was gonna say next. Anise and false unicorn, I'm very, very reserved in those as recommendation. But that is something that, because they're not super easy to access quickly. But if she's having spontaneous breakthrough bleeding, with morning sickness, that's something that I might drop off with her. But ginger and chamomile and cabbage are probably my first go-to recommendations.
Horehound too.
Yeah, horehound, even horehound candy, like literally
Yep.
it works. It works for some women. Yep. Also encouraging even now, frequent eating. Okay, because sometimes it's just because their stomach acid gets a little too wonky. And normally if we're not pregnant, just that little subtle shift, our bodies don't register that. Okay, but with the HCG and the progesterone shifting, that can make us a little bit more sensitive to normal stomach acid changes. And then that might trigger some indigestion or some early heartburn. And even just like having 2 bites of a protein and a fat can be enough for our bodies to not overly react to normal stomach acid changes after post 2-hour digestion.
Can I interject? What did somebody say about the horehound candy?
Just the horehound candy that you can find at the store can be helpful for morning sickness. Yep. I've made horehound honey where I just soak horehound in honey, and then I'll take that over if they're really struggling with nauseous feeling, not to the point where they're actually throwing up. Okay, because then that's different. But if they're just kind of having food aversion, that one bite doesn't alleviate. What's another thing? Kind of that motion sickness feeling where they're kind of on the verge of it, but it never fully gets to throwing up. Because if it gets to that actual throwing up and even like throwing up water, then something like homemade diclegis, which we'll talk about more in when there's actually a problem. These are normal changes. Like there's not necessarily a problem. These can be normal responses, sensitivity responsive to normal hormone changes. Okay. Anything else on this one? Okay, so when we do get to have first trimester checkups, I usually actually don't even if they did contact me in the first trimester, I usually don't do a lot of in-person first trimester checkups. Okay. I usually wait until the 15th week, partly because that's when my Doppler can be most reassuring. Okay. And not that I'm withholding that tool from women, but sometimes, even if they say that they understand, but then I can't get reassuring tones, that can be very mentally and emotionally hard on women. So my first trimester checkups tend to just be over text or phone calls. Okay. And it tends to be focused around, the diet and the physical things that are going on, encouraging rest, normalizing a lot of things that she's experiencing. If she is experiencing some spotting, we talk about that. I might drop something off, but I tend to not do like a full physical in-person first trimester checkup. Deciding what you want to chart in the first trimester. Do you want how do you want to develop your style of charting? I usually don't start my charting until the first in-person full physical one. Again, tend to be like that 15-ish week mark. What else? For me, that's really about it. What do you think, Twin?
So I do it a little bit different because of the demands on my calendar and the fact that I have an electronic chart.
Oh yeah.
So in the first trimester, I'm sending them health studies, I'm sending them submissions, and my Doppler can reasonably get heart tones between 10 and 12 weeks. If you've got a little, that's going to be a little bit harder for me to get.
You're breaking up a lot.
Shoot.
So I just
How's that?
Better. But that just made me remember I just had a first at 17 weeks, but she has a tilted uterus and I couldn't find reassuring heart tones. So just because you wait that 15 weeks doesn't always, she has a posteriorly tilted uterus, and even at 17 weeks, baby was able to tuck into a right posterior pocket, and I could get a count, but I couldn't get auditory feedback. So even waiting that, it doesn't guarantee. And if they're choosing not to have concurrent care, a lot of times if they're choosing to go in and have labs and have an 8 or 10 week ultrasound, there's enough reassurance where they might not be looking for an in-person at that time. But I think where Jade was going with that is, so she utilizes electronic charting, and she sends documentations and history questions, and so she's establishing all that in that time. I don't have a super full calendar, so I still do paper charting. It's not cost effective for me to have electronic charts. So those are considerations.
There was a question in the chat about Dopplers. Where are we getting them and which ones are most sensitive? Do we want to take a gander at that real fast, or do you want me to try to just respond in the chat?
No, I can do that real. So what's the name of that one, our backup one that we have?
You have a Eden S3, right?
No, I have a Huntley now, but I had an
Huntley
Eden
now.
Yeah, I have a Huntley now. So
Okay.
it's Dopplers are an investment for sure, and you don't have to start with Huntleys. You can find,
Or even a life stop.
yeah, or even a life stop. I mean, you can get some really good ones for about $250. You know, mine was on sale for $700, and this is my, I mean, I just graduated up into that like less than 2 years ago, but I was hanging with the $400 Dopplers for 10 years. But I didn't have a waterproof one until just recently, you know, so you don't have to be in the $700, $800, $1,100 range to have a good reliable Doppler. I mean, you can find one for $100.
So, yeah. So my student uses an Eden. I
Yeah,
think it's Eden by Sonatrack. Is that who it is? Sonatrack?
I'll find it real
Um,
quick. I have it saved.
But I use a life stop 3 megahertz with a 2 megahertz waterproof detachable probe. And then I also have a Huntley that is waterproof at a 3 megahertz. And it has a where I can graph fetal heart tones as part of that Doppler.
Yeah. So the Eden SD3 ultrasonic pocket Doppler, which is solid. It's a great,
It's a good Doppler.
it's a good
It's a
Doppler.
beginning Doppler.
This one is on sale for $94. The Eden Sonotrax vascular Doppler is $120 on this one. Mine is a 2 megahertz. I mean, you can get them all the way up to 7 or 9, and the seven, I mean, you could definitely get reliable heart tones with a 7 megahertz Doppler at like 10 weeks, 11 weeks. I choose to
But
use
it's only, but those ones are really, it's not gonna work for you after that time though.
yeah. Yeah,
Yeah,
so
run a 2
straight
or a
up.
3. Don't waste your money on a vascular Doppler.
Yeah. Yeah, 2 megahertz, 3 megahertz that's going to be the range that's going
Totally
to serve you the
fine.
best
Yep.
through the whole pregnancy. Yeah.
2 megahertz is better on women that have a little bit more real estate because the window is smaller.
Mm-hmm.
So it can kind of get through that adipose tissue a little bit better, but you have to be right on top of that baby.
Yeah, and that's where
get
the trade-off consideration is. The fundus has to be far enough away from the pubic bone, which for most women isn't gonna be enough until like 12 or 14 weeks. Yeah. Anything else in the chat, or was that helpful? Was that kind of what you were wondering about, whoever threw it in?
I think, yeah, that was Shoshana and Cheyenne.
Yeah,
Okay.
that was really helpful. Thank you.
And as far as where you can get them, Precious Arrows has sales all the time. I've seen sales on eBay.
I just Googled Eden Doppler, and I mean, you can find
they're
it.
the company websites. But Precious Arrows seems to be the cheapest that I've found. I don't always buy from her, but she is the least expensive. Sometimes the Doppler companies will run sales. Sometimes you could go on midwifery buy and sell places.
Yeah.
And you can get a used one.
Yep. Okay, anything else about checkups and first trimester checkups and charting? Okay, so concurrent care, elective versus required. So if they want to establish care for labs, or for, you know, they want the dating ultrasound, you know, that might change when you see them, or early first trimester communication. It's different with every person, the line of like overwhelming them and feeling like you're hounding them versus like feeling like they have enough information and enough support. It's, I don't want to say it's hit and miss, but it's really different. It's really different with every person, and I can't necessarily contextualize it in like first time mom versus multiple time moms, because sometimes because of their history, either pregnancy history or pregnancy experiences or labor experiences, they might want, like they might be texting you every day because they're reading something on Google, or you know, they got the dating ultrasound and the ultrasound tech made some comment. And it's really, I don't know how to describe it. It's really figuring out what feels reassuring to them, but then also what are your boundaries too. You know, this could be an area where you might have to set the precedent of, you know, boundaries of your care. I had to incorporate basically office hours or business hours in my contract because I didn't want to be not hassled. It's not that not that way, but I had one mom in late first trimester. She was messaging me at midnight, and then the next day she's like, well, did you see it? Did you answer me that? I'm like, it's midnight and you're 11 weeks pregnant. I don't think I need to prioritize having a conversation at midnight about GBS when you're 10 weeks pregnant. You know, so in my contract, I had to incorporate, if you're prior to 37 weeks, like I will answer all your questions within 2 hours from the time of 9 in the morning to 7 at night. Because anything prior in that time frame, like majority of the time there's going to be time, like I don't need to answer those questions at 3 o'clock in the morning. But if they are having concurrent care, what are they probably experiencing, or what are the questions that you're probably going to be asked? Okay, so knowing what's the routine from the facilities that they're probably getting concurrent care for. You know, what's their routine pregnancy determination? Is it a blood test? Is it quantitative versus qualitative? Is it just a urine test? Knowing what the facility's standard blood panel looks like. Or, you know, do you want to just request a copy of those right away? Or do you just want to or do you want them to get a copy of it and then they give it to you? You know, determining what level of communication that you establish with the clinic or not. Most of the time, I just wait for them, because now everybody's charts are online and they can just send me screenshots of their online charts, and that's good enough. If they bring up routine or non-routine, like, well, I have a consult, I'm 11 weeks and I have my MFM consult next week. Well, I know right away that's not a routine consultation. So what else is going on? Not everybody at 12 weeks gets an MFM consult. So then do you follow up with questions from that? Or do you wait until those results come in to figure out like what was their concern or what are they looking at? Same with ultrasounds, you know, picking up on I had my 8-week dating ultrasound and then they want me to come back in 2 weeks. Well, that's not usually a standard follow-up after the 8-week dating ultrasound. So that might be enough to be like, okay, well, can you, would you mind sending me screenshots when that report is posted to your online charts? Any thoughts on this, Jade? Or are you in kind of a crappy service area?
No, so I like clinical notes. So what I do is I get a blanket release of information from my client and I fax it over. And then the facility has to send me everything. And I mean everything, because the things that they are not releasing to the client in their little client portal are all the things that I'm not releasing to my client in my client portal usually either. So labs, things like that, I often do tell them, do you have any problem with an STI screen? And if they're like, oh my gosh, yes, I didn't need that, I would say, well, that's in the standard OB screen.
Yeah.
And so just giving them a little bit of information that they can, you know, really make an informed decision about. Those screens are really expensive. A lot of my clients are cash pay or high deductible pay. And so, you know, keeping those costs down for them is, you know, is warranted.
Yep. And even knowing a facility's standard, you know, because sometimes, especially if we have a young person that has a lot of facility anxiety, and they might come to you first for those conversations of like, well, I think I'm pregnant, but I haven't gone to the clinic yet. So knowing what their standard is, and like, okay, well, they're probably going to do a blood test, or they're going to ask if you want a blood test, and this is what the blood test is, and this is all the things that they're looking for. So this could be a really good consideration of just knowing either your IHS clinic or, you know, however it works for your area, knowing what their standard panels are, or their standard of like, yes, now we can, you've done the blood test, and then you did the P test in our facility, but then the quantitative blood test, HCG test, is elective. Okay, well, that might make a difference. Or like, for most places, an STI and an HIV test is on their standard panel. Well, if it's going to be shocking to see that after the fact, you know, having that conversation ahead of time can be very helpful. Either, or it can be a recommendation that you make. Like if there's a concern about sexual assault, or if it's an unwanted pregnancy, or if it was an unwanted sexual event, or if they're, you know, not sure who the partner is, or, you know, so knowing what the procedure is can really help with those conversations.
And I think like she was saying, you know, if someone says, oh, I got my MFM appointment, that should be a fat red flag for you, because that's maternal fetal medicine. They think something is wrong.
Yep.
Same with a follow-up dating ultrasound. They probably did not see a baby in there, and they want to just make sure that there is some fetal development by the time you come back.
Mm-hmm.
So kind of knowing what they order and what they're looking for also helps you, you know, tailor your care. If you've got someone with an unsure, you know, due date, but they go and get an 8 to 9 week dating ultrasound, well, you're pretty solid on your due date then, irrespective of whether or not you know her LMP.
Yeah.
But if you say, well, I got an ultrasound and I was 11 weeks pregnant, well, that's not good enough for me. Because your window for dating is really, actually, you've passed it.
Yep.
It's not as accurate at that point. Those early ultrasounds, which a lot of our clients either cannot get or don't want, you know, for a couple of clients, if there's a pregnancy outreach center nearby, I'll send for a dating ultrasound.
You kind of broke up on that, but I think you were talking about Yeah, you kind of broke up on that last
you hear
thought, but I
me?
think that you were talking about like free clinic options, or like they're not
Yes.
called women's resource centers. Sometimes
That
they'll
are
have,
pregnant, yeah, or pregnancy outreach.
yeah.
A
Sometimes
lot
they'll
of times they'll do a
really,
free dating ultrasound.
mm-hmm. Yep. Also, you know, sometimes it can feel like really detrimental information. Like if a young, it doesn't have to be a young person, I guess I shouldn't say it like that, but if a woman comes in and she's like, yeah, I think I'm about 10 weeks, and you have the conversation and she decides to go in, and you're like, okay, well, this could be a really good time if you want a dating ultrasound, you know, this is the most reliable time. But then she goes in and they're like, well, you're 14 weeks pregnant, you know, like, then that can drastically change the conversation. It can also put some potential life choices or life events, or, you know, conceptual situations that can really change how first trimester visits go. Anyway, any thoughts or reflections or questions coming up with any of this? So the whole point is, you know, even though it's not, I don't recommend concurrent care. I don't require it. I don't require testing. You know, if somebody, for whatever reason, either religious or resource access or travel ability, or, you know, medical bias, if they don't want the blood tests and stuff, I don't require it in my care. I don't require dating ultrasounds, but I do create the conversation of, okay, that's fine, but then these pieces of information, I just won't know. And as long as you're cool with that, I'm cool with that. It's your body. Right. Twins. So, first trimester. So, just real quick, 2 main types of twins. Okay. Di twins are 2 eggs, 2 sperm. Genetically, it's no different than full siblings. They just happen to be at the same time. Okay. Mono twins, there was 1 egg, and it could have been 2 sperm, or it could have been a single sperm. And division, if it happens early before implantation, or if it happens in the development in the fallopian tube, or if it happens like right before implantation, that's going to influence if it's what type of di twins, or mono twins it is. Okay, but if it was 1 egg and 2 sperm, that division will happen sooner. It will happen in the fallopian tube. If it was 1 egg and 1 sperm, that division tends to happen later. And sometimes it happens after implantation. Okay. The only way that twins can be of 2 different genders is 2 eggs and 2 sperms. Okay. So if it's like, yeah, my twins are boy girls, you automatically know that was 2 eggs, 2 sperms. It's no different than having full siblings from 2 separate singleton pregnancies. Genetically, they're just like 2 separate full siblings, but they happen in the uterus at the same time.
Sure, baby. Sure birthday.
Yep. Okay. Mono twins, again, if they're mono dis or mono monos, if they're mono dis, that division probably happened earlier. Okay. If they're mono monos, that division happened probably after implantation. Okay. That makes sense. Most of the time, the first indicator of,
Does everybody understand what the mono and the di mean?
Yeah, sorry. So die, 2 sacs, 2 placentas. Again, that's 2 eggs, 2 sperm. Genetically, they're no different than full siblings. That could be a boy-girl twin. That's the only way boy-girl twins can happen is die. Okay. Mono 1 placenta, mono die 1 placenta, 2 sacs. So that division probably happened earlier. Monos 1 placenta, 1 sac. So that division probably happened after implantation.
So the chorion and the amnion were already forming.
Yeah. Okay, everybody tracking with that? Most of the time, the first indicator is insanely early positive pregnancy test or a quantitative pregnancy blood serum that's like off the charts. Like it's triple the value that it should be. Or if they have if they're like, well, I kind of feel funny, but you know, my period's not for another 2 weeks. You know, it's technically, I probably won't get a positive. It's still kind of early. I only just ovulated like 5 days ago. But I'm gonna take it anyway, and it's immediately positive. That's probably a twin pregnancy test. Okay, so here's just another look at it to help it solidify in the brain. Okay, so developmentally, you know, I mean, not too much, not much we can influence right now. Okay, again, encouragement with rest and food and, you know, feeding the body so it can do all of its functions. Okay, but what are the concerns? Like, so historically, the big concern with mono dyes is TTTS, twin to twin transfusion syndrome. There's a little bit of a debate in when this potentially establishes in the literature, but actually Dr. Hayes did an excellent presentation, and I actually want to find this because it's supposed to be in our stuff from Rebecca from that, but I haven't looked into it. But now they're starting to surmise that actually die twins have more detrimental problems with TTTS, that mono die or mono twins are actually not the greatest twin situation that are at risk of this, but that it's when die twins implant too close together, where in early in the pregnancy, the placentas become too infused with each other. And then that's when TTTS, that is potentially catastrophic to the thriving of one of the twins, can happen.
It's the shared blood supply is what does it.
Yeah.
Where the risk is. The risk is in the shared blood supply.
But that research actually might not be in most obstetricians' Rolodex yet. So a lot of main medical structure obstetricians are still focusing on monos and mono dyes being the most, quote unquote, most dangerous for TTTS. But now that new research, and we'll find it for you guys, we'll make it accessible, but the new research that Dr. Hayes presented last year at the Twins in Breach is starting to infer that potentially dyes might be more at risk for detrimental TTTS. And when the two separate conceptions implant too close together. Okay. And other concerns with first trimester is vanishing twin syndrome. where she might think that she is having a miscarriage, but then she still happens to be pregnant. Krieger, my 13-year-old, I experienced this with his pregnancy. And in hindsight, my best guess is that I had a viable conception, which was him, and then a molar conception because it was like a stinking bloodbath where I thought that I might be like bleeding in the bed, and it was like super, super painful. Anyway, so this can be a source of like first trimester bleeding where you think you're having a full-on period, but then you still don't kind of feel right, and you're like, what the heck, why is this test positive when I just like bled like a stuck pig? I'm not trying to be graphic, but that's how I felt in the moment. So that is a possibility as well. Is there was 2 conceptions, but for whatever reason, you know, lots of checks and balances going on. Everything has to line up developmentally, and for whatever reason, one of those conceptions wasn't, but one conception was able to implant well enough where that pregnancy stayed, but the other conception did not. Okay. Anything? We don't have too much left, so if you guys need a quick bathroom break, which is me, I do.
Me too.
Okay, good. I had one quick thought about this when I was going to the bathroom, so let me know when everybody's back. Anybody else take off or just Medina?
I think just Medina, but I mean, I'm almost home, so that's good. But
Hold
I was
on,
gonna
hold
say,
on.
I'm gonna ask that client about the vanishing video.
Oh,
See if I can put it in the WhatsApp or put it somewhere where people can actually kind of see the evidence of one.
well, I have a case study about this. Remember that gal that I had? That Jewish gal in Bismarck that I had?
Yes, yes. I was
So-
thinking about her.
Mm-hmm.
My puppy. Go Steve. Ghosty, I think your dad's up there. I'm hoping to like get back in the house so I can.
Medina, are you back yet?
Let me see.
Yep, I'm
Yes.
back.
Okay, cool. Okay, so I had a thought about this. Okay, so how would we know if she feels if this is the case, or if, you know, if there's potentially first trimester spotting, and if it's a vanishing twin, or if it's a singleton pregnancy? Okay, so and we don't always. Okay, and this is rare, but it's possible. Majority of the time, if a pregnancy is trying to release, spontaneously trying to release, the body is going to be able to clean out just fine on its own. Okay, so I don't usually tap into the herbs to encourage or make sure that everything cleans out just fine. I usually tap into the system supporting herbs. Okay, because this might be happening. There might still be a viable pregnancy in there. I don't know everything that's going on. So I tend to lean into the herbs that are just going to support the system so the system can do what it's trying to do. Okay. And so the Nora teas without raspberry leaf usually is my first go-to. Okay, so because whatever hormone shift is trying to happen, that's what I'm trying to support. Okay, if there's a hormone shift that's trying to release everything and clean it out, that's what I want to support. If there's a hormone balance where the body's struggling, where if it's specifically like a vanishing twin syndrome, where one of the conceptions needs to release, but one of them has a potentiality to stay, if I'm supporting the system to do what it's trying to do, that's my goal. Okay. Now, if she starts bleeding and it's like lingering and lingering and lingering, again, I might not yet, depending on what else is going on, I probably yet won't go into like the system cleaning ones, like the black cohosh or anything like that. I'll probably incorporate false unicorn, because that's a system supporting one. I'll probably include lobelia, because whatever the body is trying to do, it just needs a little bit of help. Okay, so that was just my thought about this. And we'll get into like I said, like if spotting is lingering, or if active bleeding is going into like the 5th or 6th or 7th day, then there's probably a problem. Like when I had this, it was very painful. There was a lot of bleeding, there was a lot of clots, but it still only lasted like 3-4 days, and then it was done. And then I was an emotional wreckage, and I was all over the chart. I felt like a crazy person because my hormones were struggling. Part of my hormones are still trying to be pregnant, part of my hormones are still trying to recover. And then my husband was like, you need to go take a pregnancy test. And I dang near sent him through the wall. I'm like, I just blah, 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 blah. But 10 days later, I was still having positive pregnancy tests. Okay, so and I hadn't yet become a student of pregnancy and birth at all. I literally didn't know what was going on. I thought I was losing my dang gourd, but so sometimes if it's a vanishing twin syndrome, like you'll have that experience, but then you'll still be peeing positive on the test because you are still pregnant. Okay, that was my only thought about that. Okay, any questions, thoughts, or reflections? That was our topic list from the unit.
Thanks for talking about that.
Yeah. Excuse me.
Hold on, guys.
Okay, so our case studies were great. I really enjoyed it. I thought your case studies are great. You know, the candid response and then the 4 topic reflections at the end. You know, other than what Jade had already said about the RH negative mom, I can't really poke holes and that's not even really a hole to poke either, because that would have came back around in subsequent checkups too. So I thought they were great. I am super, super happy and pleased that, you know, you guys are right on track by the third and fourth case study. I thought they were fantastic. You got anything there, Twin? Are you still getting in the house?
Yeah, sorry about that. I don't know why this is not working. I think it's trying to pick up my Wi-Fi. Can you hear me?
Yeah.
Okay. What I think is that I thought they were all really great. And I liked people thought outside the box. Some people thought, you know, possible sex trafficking on a, you know, grand multip with a lot of babies, which in certain communities, we need to be looking at that. So that was a good thing that people thought outside the box on. I liked that it was in the correct format. Everybody nailed that. So yeah, those were a pleasure to read, and I enjoyed kind of going down the rabbit hole of how people kind of put their thoughts into play. And so yeah, well done.
Yeah, I thought they were fantastic too. So do you guys, anybody want to, now that you've had a little bit more time to digest them, you know, any other thoughts come up with them, or questions, or you guys want to ask anything about them or reflect on anything? Otherwise, that's literally all I got about them. I was like, dang, these guys are really nailing it already. Not that I thought it
and
was
those
like a
are
great
two actual clients.
Yeah.
Those are two of my actual clients.
For me, when I think it was you, Jade, that said like every line in their like message when they do an inquiry or they reach out to you, there's like something there. So that's what I did, was I printed out the case studies and I kind of like went through every sentence, every line, and thought, okay, what questions, what are they telling me and what are they not telling me? What questions would be helpful for me to know based on like just how they're saying things. So that was helpful for this one for me. I think the second case study 4 was really interesting. I think in my even my own notes, I was like, slow your roll, Amy. So yeah, that was an interesting one to have on here.
Yeah, and that was verbatim her consult follow-up email to me. Literally verbatim.
So I did a Google search to find out, you know, what she was suffering from in her anxiety. And when, like Pearl said, going through each sentence, you know, and breaking it down to what she's saying and what she's not saying. And I could feel the anxiety, even though it was just written, you know, and it was giving me anxiety. And I was like,
try
you know
serving her.
I put myself in her shoes after learning what she suffers from, what she's, you know, and I'm like, okay, I need to calm down and recenter myself and not think of it like, oh my God, this is going to be you know, a heavy workload with this person with all her questions. She's going to, you know, I just saw the future of her asking all these questions as part of her anxiety. And I know what that's like to have, you know, that high
there were a
anxiety.
couple people that were like, hell no. And I think that that's important for you to set your boundary right out of the gate and to say, because she was for the next 8 months, and beyond, she, every single email was that way. every single phone conversation, every single prenatal. And that was hard. And I think that if you know right out of the gate about yourself that, oh man, maybe as a baby midwife, I'm gonna kick these gals loose to somebody else. Don't feel bad about that. Don't feel bad about that.
Well, that's like I had just mentioned. I have a case study about a twin pregnancy where one of them was a blighted ovum. Okay. And if I would have been a baby midwife, I probably would have recused myself because there was so much PMAD already going on before she even found out that one of the conceptions was a blighted ovum. And because of the history of loss and lots of conception frustrations with the hospital, and it still didn't go well, but knowing and being okay and validating if that's your boundary, like, I'm not sure if I'm the best person to support you with this, that's okay. We're both really huge components, especially as baby midwives. When you first choose to start supporting, you shouldn't take everybody. Not everybody should be somebody that you feel comfortable supporting, and really knowing that about yourself, and knowing and not feeling bad if you're their only, quote unquote, you're their only option to have a home birth. Okay. Not feeling bad if you're not able to support them, or having the conversation of like with this one, I was like, I've never supported this situation. I don't know how this is going to turn out, but I will do the best that I can for you. I'll always be honest with you, and I need you to be transparent. If you're starting to feel the emotional things that you've experienced with previous conception frustrations, like, we need to have those conversations. Okay. And that can be very hard, especially when there is so much emotion, either PMAD situations or anxiety, or like whatever the perception or their experiences are. Like, it can be really, really hard. And it can be really hard to not feel responsible to carry those as the midwife. Can't hear you, twin. I see your mouth moving, but I don't hear nothing.
I said, especially if you're the only game in town.
Yeah. Yep.
You may feel obligated.
Well, I'd like to add to
go
that
outside your
piece is
comfort
that
zone.
we are not the only ones out there. Don't fool yourself, because each of these families are going to search, and they're going to search, and they're going to search, and they will find somebody. So don't ever think that you are going to ever be the only one that's going to serve these women who are pregnant with these issues. Those are some of the things that I've come across, and just recently. And it is, they're going to go wherever even if they're the ones who have to travel far. But if they want that home birth and they're not going to take advice, then let them release them.
Yep.
Let them make their own choices. It's not about you after a while. It's really, really not about any of us. And I've worked with, like I said, I've worked with several different midwives, and some of them, it was always about them every single time. And that got to be really, really old. And it got to be really unsafe.
Yeah. Yep. And sometimes it comes out sideways, and they attack your reputation and then decide to go to the hospital, and they blast you all over Facebook and say some really nasty things about you as a person and as a midwife that had nothing to do with you, and they're all about their own choices, but that's how it comes out. And it really sucks. Okay.
Well, I just want to say one thing. As I was watching you girls, ladies tonight, I really saw beauty in how you are learning and how you're responding, and how, I didn't get a chance to read the case studies, so I didn't get to read the case studies at all, but I will. But just know that you are getting it. You are having a better understanding of it. And what I saw the most is that you're speaking up, and you're not, you're past that point now. You're really past that point. You guys can speak up and say what you need to say, and because those are really important in my eyes, to hear your guys' voice. But I saw beauty tonight. I can honestly say I saw the beauty of learning and understanding from each and every one of you. So I thank you for that. And I also want to say too, no, I'm teasing. I heard that there are some midwifery programs that are not doing so well, that are online. So, we might be one and only. So, and being all Native American group, that's very important. You guys are going to be making a statement, not just on our behalf, but for hanging in there and putting the good work in, and all the research, and because it's you five that are going to make it. And so you guys have all the time in the next 2 years now to really become reliable on each other.
Yep. Yeah, there's 2 direct entry programs that shut down.
Yep.
Whoa. So anything else?
Did anybody have any questions on that? On the case studies themselves? Was there something that you couldn't figure out?
I just wouldn't mind knowing what else I can put in. Do you want the types of tests I think about or wonder about, or do you want like what else I can be putting in?
If you want to put those in, yeah, we could find that helpful, because we could say, hey, what are your thinking? What are your thoughts on that? Right? Like, what are you thinking about? Oh, you want to order that test or not? But what we're looking for is exactly what we got from you guys.
Yeah. Yep. If those are considerations that you will follow up with them or take into the next prenatal or include in the next,
or that's going to be part of your practice style.
Yeah, for sure. Yeah. If that's what you're going to respond with or take back into the, and maybe it's not in your initial response, but if that's something that you're going to revisit the next time that you have a prenatal, yeah, that can totally be in your 5-topic reflection. Even if it's not in your initial response, because this one was an email and a text or voicemail. I don't remember. Anyway, but if that's something that you're kind of going to put a sticky note to revisit in the next prenatal or bring up in a conversation down the road, yeah, you can definitely include it. I don't think that anything specific was a wrong approach or something that was drastically missing or anything like that. So if you want to include that because that's something that you're going to feel like you're going to incorporate into your style of care and practice now, and maybe in 10 case studies it's different, sure, include it.
I had a question on postpartum preeclampsia. I looked up a little bit of info on it, and I tried to remember if I had read anything else on it. But I know preeclampsia, you have a higher chance of having it again in another pregnancy, right? And postpartum is that one can be anywhere from weeks later to immediately postpartum. Is there I guess, is the treatment the same? What do people do for their postpartum preeclampsia when they've had it previously and they're now pregnant again? Does that increase their chances of postpartum preeclampsia in this pregnancy?
So you want to go first,
it-
Twin, or you want me to go? Because I just had one.
Well, I'll kind of do it superficially and then you can take the deep dive. So postpartum preeclampsia, you don't have to have preeclampsia or signs and symptoms of preeclampsia in pregnancy or labor to experience postpartum preeclampsia. It can develop spontaneously, immediately after labor. And I've never dealt with it in real life, so all of mine is theory. But my understanding is it does not guarantee that you'll experience it every single time. It doesn't guarantee that you will, and it doesn't necessarily guarantee that you have a higher risk of developing it in the immediate postpartum more than anybody else that's never experienced it. Okay. And my understanding is that similar to pregnancy preeclamptic, there can be lifestyle self-care choices to reduce it happening again. And I'll tap you in after that. Go ahead.
So we just had a postpartum preeclampsia with pulmonary edema with only one elevated blood pressure in her pregnancy, and it was in late labor, active labor, about, I don't know, 3 or 4 hours before she started pushing. And I don't always normally get a blood pressure at this point because I think that you're going to have a cardiac response to pain. So I expect your blood pressure to be a little bit higher. But she was acting weird. Like, she was super breathless. She was acting weird. She had a history of pre-E in a previous pregnancy where she was on blood pressure medication and ended up having a hospital birth with that baby, due to severe hypertension. So we asked her to go in because, of course, she's 3 hours away. What she was reporting to me was shortness of breath, that was the thing that I had to look up in Barney's. She was reporting shortness of breath, elevated blood pressure, and that she couldn't pee.
Yeah.
And she wasn't having any visual disturbances yet, but she went in. They initially diagnosed her with peripartum cardiomyopathy, which is a really bad day. They ended up downgrading that diagnosis to postpartum pre-E only with pulmonary edema. She went home with 2 weeks of labetalol, which is a blood pressure medication, and Lasix to take all the fluid. She had fluid around her heart, fluid around her lungs, and fluid in her lungs, all from the postpartum pre-E. She did not report these symptoms right away. Had she reported those symptoms right away, I might have tried to do some diet and herbs for a couple of days to see if we could get her blood pressure to rally, because that's what we had done all through her pregnancy.
Is this Daisy?
She kind of, no. She kind of fell off the wagon with her diet after her pregnancy and after she had her baby, and didn't think that she needed to eat 200 grams protein anymore, and through some postpartum pre-E. So she ended up being hospitalized in Bismarck for 3 days, and she's home now, and doing okay. She has another week or so of BP medication. But before I would have sent her in, I would have gone over those dietary guidelines again, and herbs, and like, what are you doing? Like, what's happening? Are you salting your water?
How long postpartum was she when this developed? Is it like 2 weeks?
She was 10
Yeah.
days.
Yeah.
And she had been symptomatic for 3 days.
Yeah. So actually I thought in my last labor that I supported, I thought I actually might be seeing my first case of immediate postpartum preeclampsia. This was a late to care mom, and she was a G3P1. And in her first pregnancy, she had a diagnosis of cholestasis with a liver bile enzyme of 54. 10 is the diagnostic line. So she had an induction at 38 weeks that ended in a C-section. Second pregnancy was early term spontaneous loss. And this was her third that she contacted me at 35 weeks. Oh. And so established care, fast forward, and she was 38, like 38 and 2. And she started having some emotional concerns pop up about like wanting to go in labor, doesn't want to be pregnant anymore, like, you know, all the things, right? So a little bit of PMAD stuff, but you know, that was the week that shit hit the fan in her first pregnancy, right? That's when she got her cholestasis diagnosis. That's when she had a failed induction that resulted. So I knew the 38th week was going to be tough, right? So fast forward, she's in spontaneous labor. You know, she's reporting 6 out of 10 on the pain scale, these contractions every 3 minutes. I go over and check on her. She is definitely not a 6 out of 10. I sat at the table with her for like 40 minutes and I did not see her. I could not discern one single contraction in her demeanor, how she was coping with it. She sat at the table the entire time. And I was like, okay, there's a lot emotionally going on. Okay, well, fast forward a couple hours, she does go into labor. And at deeper into labor, literally like 7.5 hours of emotional dystocia. Okay. She finally gets to the pushing stage, productive pushing where baby's crowning. Baby comes out and it doesn't immediately, like, she doesn't look at baby, she doesn't reach for baby, she doesn't engage with baby, which isn't always an issue. That's not always a red marker or a red flag or anything like that. I held baby, I waited for her to like collect her bearings and like be ready to reach for baby or ask baby for her on their chest. We got her comfortable on the floor. She was pushing on her hands and knees on the floor. And we get her leaning back and she finally makes a motion to like reach for baby. Okay. Dad announces gender, baby's on her chest, and she is staring off into space.
Oh.
Like not interacting, not looking at baby, not like talking with her husband, just like totally blank, not registering, like hardcore staring off to the corner of the room. And I tap her leg, I get her to like respond to me. And I had to do that like 3 times. And that just like total disassociation. One of the first 3 things that go through my mind is like, are you about to stroke out on me? I was watching her eyes, like, yeah, just total emotional disassociation and like not wanting to look at her baby. And she did have a few blood pressure concerns, but it was what I was able to piece together. She was intentionally trying to disassociate emotionally. Like yeah, but it wasn't postpartum preeclampsia or eclampsia or anything like that. It's emotional things. But, you know, it is one of the things that went through my mind as I was watching this unfold. Anything else?
I have a question in regards to RH. So like if you're doing preconception work or like doing coming of age stuff, you know, and you
Mhm.
start talking about, you know,
Yeah.
when that time comes and you want to become a mother. Can you test before she's pregnant for RH? So
Yeah,
then
you
you
could do
kind of,
those. Yeah, you could do those Eldon cards. You can get a pack of 7 for like $20 on Amazon. ELDON Eldon cards.
okay,
Yeah, that could totally be something that you do in preconception, or like you're saying, coming of age, or just annual wellness checking.
yeah,
You know, it is a good piece of information to have, you know, and if they've never and it's not just because they've had their blood tested doesn't mean that it's on their charts. Like it specifically has to be requested. It's, to my understanding, it used to be a standard if they donate blood, but now I guess it's not. You still have to request it. So they might never get blood typed ever, you know. So that could totally be incorporated into your you know, self-awareness, self-wellness, supportive care. Yep. Okay. Anything else? Okay, I'll open unit 8 tonight. A couple things I still need to add. I'll post this in unit 7. This will still be, so unit 7 will still be accessible until like Wednesday or Thursday. And then our normal, you know, unit 8 will be open. You just got to open it. Because when I make it for free, I can only leave it open for so many days, blah, 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 platform restrictions, yada, yada. Otherwise, we will keep moving forward. Back on track. Yeah. And if somebody could tell me where my camper keys are, that'd be super awesome.
Oh, no,
Yeah.
no.